Human Services meeting. Again, May 9th, 2016 Human Services Committee meeting being called to order. First of all, we're looking for an approval of the agenda.
So moved.
We have a motion and support in favor of the agenda as printed in board docs. Are there any comments, questions, adjustments that need to be made? Seeing none, all in favor say aye.
Aye.
Opposed? We have the agenda. Next, we have public comment. Is there anyone that would like to address the board? Again, looking for anyone that would like to address the Human Services Committee. Seeing none, we will move on to our first committee item, which is the meeting minutes of April 11th, 2016. We have a motion and support of those meeting minutes that are printed. Are there any questions, additions, comments, corrections? Seeing none, all in favor say aye. Aye. Opposed, the same. Meeting minutes are approved. Next on the agenda, we have the medical examiner's report. Good afternoon.
Good afternoon, Commissioners. Dr. Mano from the Medical Examiner's Office, and we submitted to you to date, the Medical Examiner report from 2006 through 2015. So if you have any questions, I can address them. But so far this year, from in 2016 as of May 9th, we have had 17 accidental deaths, 1 homicide, 84 natural deaths, 10 that are pending and still being evaluated, 3 suicides, and 18 undeterminable. Under those undeterminable deaths, 16 of those have been attributed to overdoses of drugs. And of our suicides that we've had, 1 was a gunshot injury, the other is a hanging, and then the other is a train incident with that, and the homicide was a gunshot wound or gunshot injury. The others that we have on our accidental deaths so far this year, we have 3 motor vehicle accidents, 12 falls, 1 fire, and 1 choking. And as you can see from our report, as of 2015, we had 175 cases that we autopsied, which is our highest that we have ever had. And the incident is continuing, to grow. And we expect that if it continues at the current pace, we're going to be greater this year than we were last year. We may be as high as, 200 autopsies. Now, one of the things that is contributing, I think, to that is that Henry Ford Allegiance has applied for a Category 2 trauma, to be a trauma center. And part of those patients, that die from, falls, accidents, and trauma are usually classified as accidental deaths in one form or the other, or even, homicides or suicides that that live. And in those situations, if they end up dying, it's required, that we autopsy those. In the past, all of those had been, primarily shipped to Ann Arbor, where, they would have been investigated there, but now we're being forced. Or not being forced, but it's part of our responsibility, because it's the responsibility of the medical examiner's office in the jurisdiction that the patient dies that we have to investigate. And
Right.
that's
I guess,
essentially
you know what, and I never would have given any thought to that in regard to the Henry Ford Allegiance being a trauma to center.
Yeah, and with the trauma, that means that we're going to be recruiting and receiving, other, trauma accidents and trauma victims, from other areas, which could be Lenawee, Hillsdale, and even Calhoun. But because they die in Jackson County, it becomes our responsibility to investigate by law. It's the county that they die in that becomes the responsibility for the investigation.
What comments or questions might you have for Dr. Mano? Well, and again, appreciate the graphs and the information that you made available to us. Commissioner Leitner?
I looked through your report as well, and I was just curious if also you have seen, like on your drug, alcohol related, on your undeterminable, can you tell us like if they're opiate related or other drugs, or is that part of the, well, we don't know, it's just drugs, it's classified, because with the heroin and opiate situations that we have right now in the county, and even on the prosecution side, and then obviously resulting in deaths, I just wondered, is that something that you can break out even further, or no?
On the details of each of the investigations, yes, we can, but when we report this, it just comes under a category, of drug overdose. And the majority of the drug overdoses are opiate and heroin related. And many of them are also or what we call polysubstance abuse, okay? Usually, there's cocaine, heroin, other medications that are mixed in with it, and alcohol. Usually it's not just one drug that is involved.
So as a follow-up question to that then, if we compare the two charts, the one being manner, suicide, and you have drugs, alcohol, poisoning, and then the table after that is manner undeterminable.
Undeterminable manner means, that we really don't know, okay? What ends up happening is if someone dies from a heart attack, it's, a natural death. Okay, with undeterminable, you don't know, is it accidental? Was it a homicide? Was it, self-induced, suicide? We can't tell, and so those get reported, and many drug overdoses, or a big portion of them get reported as undeterminable, because we don't know what the intent was or how it's. And, the prosecutor is now going, after the delivery, of those drugs, that contribute to it, but, the death is, still determined undeterminable. And when we classify it as a medical examiner as a homicide, it's not necessarily the same that the legal system. They're two different, classifications. For instance, if you die in the military, as a cause of, it's technically a homicide because you died as the result of the action of another person.
Commissioner Placzek?
Hi, John. You're looking more like a Harvard professor every day.
Thank you.
Can you tell, and it might not be your department, but can you tell whether Narcan and the first responders' cars have made a difference in any of those? I know the heroin deaths are way up.
Yes, I'm putting my other hat on as being the medical director of the Jackson County Medical Control, working with EMS. It first started out with the first responders because fire departments, the firemen that used to be called rescue are now under first responder and have to come under medical supervision. So they have the ability to administer epinephrine in the field to people that are having an acute anaphylactic allergic reaction because that's life-saving immediately. And then the other one is Narcan. And yes, we have had a number of saves, and resuscitations using Narcan. Now, the other thing that has happened is, having worked with Sheriff Rand, is that the police are now carrying Narcan because there are minimal side effects, to the drug, usage. The only problem with that is they technically do not come under any medical supervision, and I know that that's being looked at, from, the state level. But right now, yes, and our medical control is working with all the law enforcement agencies in Jackson to administer Narcan. So it's a three-tiered system in Jackson right now. One is if the police respond first and they think that it is a drug overdose, they can administer Narcan. If the first responder firemen respond, they can administer Narcan. And then additionally, if the paramedics arrive first or even subsequently, they can administer additional Narcan. It can be administered any way, but the first responders administer it by a nasal injection. Just like a nasal spray. Actually, the FDA is looking at right now making Narcan available over the counter as a nasal spray, and we'll see that probably in the future. They're looking at that. But many of the people who use drugs, snort, and what a lot of people don't realize is that the nasal plexus of vessels in the nasal passageway is very vascular, and the medications are absorbed very quickly.
Any other comments or questions? Seeing none, thank you for that information.
Thank you. Have a great day.
Next on the agenda, we have Lifeway's monthly report. Welcome back, Shannon.
Hi, good afternoon. Shannon Clevenger from Lifeways. As you received in your board docs, Mary Beth has presented a monthly report, and I'm just going to highlight some of the important items. The first one, we have Lieutenant Governor Calley coming to our building. It was scheduled for May 4th. It is now June 8th at 1 o'clock. He will be coming talking to stakeholders, community members, commissioners, interested parties in the community around Section 298, which is the section of the legislature that the governor initially put forward to privatize mental health systems in the state of Michigan. That has currently been taken and put aside, and Lieutenant Governor Calley is leading a work group that is visiting areas around the state to get input, and then they're going to come up with a draft language to propose for the next year's budget. So it won't be anything this year, but potentially something for next year. So again, that's June 8th at 1 o'clock. We'd love to have any of you attend. Mid-State Health Network, our prepaid inpatient health plan, came down and did a follow-up audit. We scored very well with that follow-up audit. We have a couple areas that we need to address related to co-occurring, so the substance abuse gatekeeping function that we have right now through Mid-State. There are some new standards they put in place this year around follow-up calls, and that assessment and referral piece that we can do to substance abuse providers in the community that they would like us to kind of beef up some of our procedures and policies on. You'll find the audit responses, though, in your packet. The state, again, the Section 298, Mary Beth wanted me to make sure that you were aware, before Lieutenant Governor Calley comes down, there is a website you can go to and read all of the minutes. This work group has been meeting for a little while now, and you can read all of their minutes and be able to, see kind of what the group has been discussing and be up to speed if you plan to attend that meeting with Lieutenant Governor Calley. Under legislative updates, the House and Senate committees approved the fiscal year 17 budget recommendations that were presented. They've added $1.8 million to the CMH non-Medicaid line to serve those non-Medicaid covered individuals. There is a boilerplate language that requires minimum wage increases to be included in Medicaid rate setting processes. This will help those direct care staff the most that are providing care to individuals in their own homes, an aide level qualification of staff to make sure that they are hitting that minimum wage and being protected through minimum wage, and the new, what I've heard, guidelines that may be in place for overtime and salary versus exempt, non-exempt. They've created new boilerplate language that prohibits DHHS and its contractual agents from requiring prior authorization for psychotropic medications and other protected classes of drugs, which is really important for us. We have a number of people we have to seek prior authorization for, and that can take some time for some of their psychotropic medications. And so being able to remove that will help ease and access to care for those individuals that we're serving. Highlights in the Senate budget, again, the 298, they're revising that section right now. The minimum wage is also in there. There's also an inclusion for lapse funds language from this year to next year for the Medicaid funds. And it has a boilerplate that creates a spend down work group to address the challenge and establish policy recommendations. If you're not familiar with the Department of Health and Human Services, an individual can be Medicaid eligible for services but have to pay an amount of money out of pocket to be able to access those benefits. So you could have a person who is eligible for Medicaid but have a spend down of $1,000 a month. So they technically do not have Medicaid coverage until they meet that spend down, which is out-of-pocket cost for that individual. This is something that we in the CMH system as a whole have been advocating for. We have people on fixed incomes who end up with a house, a car, and maybe have a retirement fund or an insurance policy that is counted as an asset, and it puts them in a spend down. And so they have to actually pay $1,000 a month to have insurance coverage. And so this revision, we hope, will create a new process, an updated process on financial income and eligibility benefits that will hopefully pull some of those people out of that spend down eligibility line and give them full Medicaid and or Healthy Michigan. So some type of constant coverage, not month-to-month coverage. For some of those individuals, it's a catastrophic event that gives them coverage. They go in the hospital. And it also is a detriment for them to receive access to care, so they don't go when they need to for preventative medicine and those types of things. Lastly, upcoming events, we have Walk a Mile in My Shoes, where we go up to the Capitol building for a large day of advocacy across, many CMHs from the state come. That's May 18th at the Capitol lawn at 1:15. And then the Jackson Suicide Prevention Coalition is having an event on September 22nd with Kevin Hines as a confirmed speaker, and they're going to do a walk here downtown. It's going to be at Jackson Theater.
Thank you. What comments or questions might you have for Shannon? Commissioner Rice?
What? Don't look at me that way. In regards to that 1.8 million for non-Medicaid, are you referring to that could go to CMH's GMF? Or, excuse me, GF, I'm sorry.
I'm not sure. I can follow up with Mary Beth to see whether or not that's been designated for GF.
Okay, and of that, obviously, there's a lot of CMHs in Michigan, but I'd wonder, or be curious, if it was for GF, how much Lifeways would receive.
Right, from across the state.
Yes, I mean,
I will get that for you.
1.8 million is not a lot from
No.
across the state, but I'd still be interested to see if it could add to the GF for Lifeways.
Absolutely. That would make sense where it would be delegated, but I'm not sure.
Right, well, common sense doesn't always, you get that? Okay, thank you. Madam Chairman, one more question? I'd just like to point out to the commissioners that are here that the spend down that Shannon's referring to, if somebody has like let's say $100 deductible, doesn't have to be $1,000, could be $100, could be $50, could be $500. That is set based on that person's overall income, assets, and things of that nature by the state. So it's not like somebody's walking in the door and saying, "Hey, I've got, I owe $300." Well, they owe $300 because according to the way the system's set up, they owe $300 because according to the way the system's set up, just like it is with our private insurance companies, it's based on, a lot of times it's based on how much money people make and things of that nature. But Lifeways chooses to pay people's spend down whether it's 1,000, 300, whatever it may be. Lifeway spends a lot of money on people's spend down, which actually that meets the criteria. They're supposed to pay that, but Lifeway's picks it up anyway. And the reality is, at least from my perspective, I've mentioned this many times, Lifeways does not have to pay that spend down money. They could keep that money in the GF and use it for other services in the community. So basically, we're paying for people's deductible when the standard's already been set. I'm just throwing that out there because I have some issues with that myself, but just my comment.
Correct, and follow up to Dr. Rice, those funds that we provide services for until they meet their spend on are all general fund. They don't go backwards in time. They go back to the date they actually meet that dollar amount. So anything prior to that is considered general fund dollars.
Any other comments or questions? All right, thank you, Shane.
Thank you.
Thank you. Next on the agenda, you'll see the Medical Care Facilities Financial Report from the month of March is included in Board Docs. Next on the agenda, we have Department on Aging Monthly Report. Ms. Marcy?
Good afternoon. If you see me looking over my shoulder, it's so that IT can advance the PowerPoint slide. So the report for this month, I'm just giving you a summary of a U.S. Census Bureau report on age 65 and older. Just some interesting statistics. And that's a picture of the report where I'm getting this information. So in Jackson County, over age 65, there's 22,679 individuals. This is the 2010 census report, and they tend to group their data based on 65 and older rather than 60 and older, although I do know there's 32,000 age 60 and older in the county, which is 20% of our population. And our services are for age 60 and older, and that's based on Older Americans Act grant criteria and senior millage criteria. So you've heard about baby boomers reaching age 60, 65 and older. So the population age 65 and older will grow faster than the population that's under age 65. And then the next slide shows the proportion of age 65 and older to the general population. And if you wondered what age is a baby boomer, it's someone born mid-1946 to 1964. That's considered a baby boomer, depending on which statistical report you're reading, but that's usually the one I use. And I'm just showing with 2010 census how they expect the proportion of age 65 and older to jump in the future. In living situations, just under 4% of adults age 65 and older reside in group settings such as adult foster care or nursing home facilities, assisted living. And the vast majority, 96.4%, live in households, live independently or with someone else. And just as an aside, when I first started out in gerontology, it was around 10% who lived in long-term care facilities, and so that has really dropped. I will get to that in a future slide, yes. Living alone, age 65 and older, just around 34% live alone. But as the age increases, like between 70 and age 80, the percentage who live alone increases. Usually because spouses pass away, and so the individual is now living alone. And I wanted to point out too, with the severe depression with age 65 and older, that it's not a normal part of aging, that it is something that should be looked into by someone's physician, or even someone's talking about counseling. And we do offer counseling for older adults, especially those who are homebound, because a lot of people are dealing with losses, both in health, family members, as they get older. And so that is something to be aware of, and something for people to receive help. And then the next slide, percentages of memory loss, and that does increase as a person gets older. Your chances are of having memory issues increases, but again, to not assume that it's a natural, quote, natural part of aging to have a physician look at it, because there are medical conditions that can cause memory loss, especially what you call delirium. If someone is suddenly seeing things, it could be they have a urinary tract infection. So again, it's just something to have checked out. And there are medications available to help slow the progression of memory loss. It won't reverse it, but there are some medications that can help slow it. And we do have a memory screen and a depression screen at the Department on Aging. And functional limitations, 38.6% of people age 65 and older reported that they had one or more disabilities. The most common is difficulty walking and doing errands alone. And a lot of what Department on Aging services for our home care assistants, we target that particular need. It's difficult to go and get groceries. People are more homebound and they need help with things like cleaning their house, and that's part of the services that we provide. And then the next slide, functional limitations. So this points out at age 65 to 74, just over a quarter of people had at least one disability. Age 75 to 84, that percentage increases, and age 85 and older, 73% report a disability. And this is a physical or mental or any health condition lasting for 6 months or more that limits the kind of work that a person can do, such as the difficulty going outside of home alone or taking care of personal needs. And another statistic I thought was interesting was the link statistically between education and having a disability, that people without a high school degree are 40% report a disability, and those who have some college or a college degree, it drops to 27%. And that could be due, college degree, the work they may have might be of a position that's more likely to provide a pension, so they have more income available to receive preventative health care. Next. So in Jackson County, residents age 65 and older, 35 report that they have a disability. And that brings me to talking about impact of falls. And the medical examiner briefly touched on this, just the impact it has, the chances of falling, and the importance of, again, prevention, exercise, good nutrition, maintaining balance to prevent falls. That 33% of older adults fall annually, age 65 and older, and 60% of those have an injury that then sends them to the emergency room. So that increases visits to emergency rooms, and then 25% of the people who go to the emergency room require hospitalization. Next slide. So people age 65 and older who fall 4 or more times a year are more likely to need long-term care within a year. And the next slide. Your cost of care, of course, increases. That if you can provide services in the home to help so that someone else is cleaning the bathtub and vacuuming and mopping the floor, that can help prevent falls as well. But yet, if you need care such as home care assistance, nursing home assistance, that is a valuable service, and people reside in those types of living situations because they need that level of care. So it's good that there's a variety of care. And then the next slide about Medicaid funding. This is a large reason why there's a lower percentage of people age 65 and older living in a group setting or long-term care setting, because there is more Medicaid funding. Medicare, everyone's eligible for Medicare age 65 and older, but Medicaid is if you have limited assets and limited monthly income, So the federal and state government have been moving more funds to in-home services such as Medicaid waiver program that here in Jackson County is Region 2 Area Agency on Aging, and then now also the PACE, Tomei PACE Center on Springport Road. That is to provide more services for people so they can live in their own home rather than going to a nursing home maybe prematurely. So that's a big reason, I think, on why the number, again, of people living in a group setting has gone down. And then the next slide. Those who have higher income, who are age 65 and older, it's kind of interesting, where does their money come from? And it's earnings, like maybe investment earnings, they have a pension. So the percentage of their monthly income that's from Social Security is around 17%. And the next slide, those on the lowest part of the income bracket, Social Security is a very large part of their income, 84%. And your Social Security increases by a cost of living amount every year, which is pretty minimal. So their income is fixed. And they're dependent on Social Security. And also looking at the people living in poverty in Michigan, there was a study, and 9.7% live below the poverty threshold. And if you take into account, this study takes into account what it costs for food and shelter and just to be able to live in a home or apartment, healthcare costs, that when you take into account those factors, that it's 37% that live what they call below the elder index threshold. And in Jackson County, the next slide, it's around the state average. It's a little bit higher, 37.8% below the elder index threshold. But below the census poverty threshold, it's higher than the state average, just 11.2%. So again, that was just a summary of some statistics from the 2010 census. Just give you a quick picture of what's happening. So, any questions?
Commissioners, Commissioner Rice?
It's not really a question, just a comment, and I know Marcy's aware of this, and it's for anybody here too. The Tomei PACE program, which is a program that if you qualify in terms of your Medicare and or Medicare, Medicaid, it's a program, it's like a day program, of course, like an 8 to 5 program, Monday through Friday, but one of the interesting facts about it is like a person who's part of the PACE program, if it gets to the point where they can no longer go to PACE, but they have to go to a medical care facility, they could go to the Gantons of the world, where now the Gantons of the world won't take Medicare, but if you belong to PACE and you have to go to one of the, as I call it, the Gantons of the world, Medicare will cover that and PACE will cover the rest, as opposed to a person who's not part of that program, they won't cover it. So they can actually go to a private facility and Medicare will cover it.
Thank you for that insight. Mr. Overton?
Marcy had a thought as you were speaking. I know we go to great lengths to keep people in their homes, but it occurred to me that if they're of such a state that they really can't do for themselves and go out, are we really doing them a service or a disservice by keeping them in their home? Because what occurs to me is, people are very social, and we've isolated this person. The only person they see is perhaps our Meals on Wheels people, or our person comes to clean the bathtub or help. So do you find that to be true, or is there alternatives, or what's the deal? Because I'm just thinking, I don't want to be imprisoned in my own home when I'm older. Think about it.
Mm-hmm. Right now, our focus is on the basic necessities. If you are eligible for a Medicaid waiver, they can do more services such what they call it community living supports, and have someone take the person out into the community to do, go to Target and have a cup of coffee, whatever they prefer to do. But for the Department on Aging right now, we have not expanded into that that type of service, right?
Again, my thinking is, I know we as a society have gone to great lengths to keep people out of homes, assisted living or otherwise, but perhaps there's a place for that, before, because the socialization there, they play cards, they have church service, they have all kinds of things.
Right, when we have seen people do better when we've kept track of them, who've gone into a long-term care facility because of the socialization. The issue, not issue, but in order to qualify to go to long-term care, you have to need medical assistance. You need to have a nurse around 24 hours a day. And that's where a lot of people, they're homebound, but they don't need someone with them 24 hours a day, and that's when they're not eligible to go to a larger long-term care facility. There are adult foster care homes as well, but yes, it is one. There's two requests we receive. One is transportation, and the other to shopping. There is transportation for medical appointments, and also a friendly visitor, someone to take people places for people who aren't eligible for the Medicaid waiver program.
So it's not an issue that's gone unrecognized.
Correct.
There's probably, I suppose, studies on it, and people are looking into how to resolve that issue. Because it's not just longevity, it's quality of life as well.
Right.
All right, thank you.
Thank you for that information. Seeing no other comments or questions for Marcy? Marcy, thank you for that update. Next on the agenda, we have Health Department Monthly Report. Welcome, Richard.
Thank you. Good afternoon, Commissioners. My report, of course, is in board docs in your packet, and I'll just highlight a few things that I have made some notes on since it was submitted. Under administration, we've informed you that there has been some reallocation going on of public health emergency preparedness funds for this fiscal year beginning July 1st, 2016 for those funds. This is all related to Zika virus organized prevention and control activities, if you will, that we expect the CDC is going to get actively engaged in already at this point in time of the year in the southern states. So while they're pulling 10% of our funding, if you will, actually an 8.4% reduction in our funding, totaling approximately $11,000, we may be able to use some of the Ebola special pathogen funding forward to the next fiscal year to help offset some of that. And we estimate we'd have about almost $7,000, so it's a relatively minor impact for us at this point in time. However, that said, it's also possible that some of these funds that are now allocated for Ebola and special pathogens may actually get redirected to be used for Zika prevention as well at the state or the local level. We don't know that yet, but there is a work group that's meeting with the Michigan Department of Agriculture and the DNR, composed of health officers and other Mosquito Control Association members in the state of Michigan, who are going to start talking and looking more at, do we need to be doing more surveillance in our state, in more counties, particularly those that might be more susceptible to the particular mosquito species that we're concerned about. So we've indicated an interest in participating in that particular committee or work group in the state, and we'll keep you informed as that kind of moves forward. I think everyone's probably aware at this point in time that the CDC has actually indicated that the condition called microcephaly is caused by this particular Zika virus in young children and pregnant women, if you will, that are affected and exposed to the virus. So that causative link has been made now. We did have a general staff meeting on April 6th. A lot of activity took place there. Our staff continue to do an excellent job of supporting the needs in the community. People go out and actually get registrations completed and certifications completed without necessarily being required by their position in the health department. So I think that says a lot about how dedicated our staff are to doing a great job for the community. State accreditation is coming up for us in October of this year. It's hard to believe it's already been 3 years, but it has been. So I'll be coming back to you probably in the month of June, I'm anticipating, with a request for you to review and approve our plan of organization for the health department. It doesn't change much from every 3-year cycle, but we do need to get approval and support from the board for that. So we'll bring that back to you at the appropriate time. The first week of April is National Public Health Week, and we did have some activity going on in social media with the Health Department postings concerning one of our programs each day. And I did an interview on April 8th with Bart Hawley, and we've also met with Representative Earl Pileski during that week to discuss the county health rankings for our county and public health needs, goals, and objectives for the community on April 5th. So that was a very positive meeting with Representative Pileski. Rather lengthy update here concerning the Accountable Health Communities grant. We've talked about this previously in a couple of other meetings. And, you know, the more time you spend actually developing the component pieces of a grant, the more you kind of figure out, is this really something that's right for us and the right direction for us to go with creating community and clinical linkages, if you will. And the bottom line is, as we got closer to the due date, which is actually May 18th, we kind of figured out that the prescriptiveness of the CMS model we were pursuing wasn't making us comfortable. It was pushing us in directions we weren't ready to go yet, or we simply didn't have the time and energy to create everything that this grant would require. So we stepped back from it. We decided not to make the final application, but as we're working through the process of understanding what the state innovation model looks like for Jackson County and for Henry Ford Legion's Health and us locally, there are many elements and components of that particular healthcare system transformation model that will work for us to be able to continue to push forward what we started with AHC. So we don't feel we're losing anything. We'll continue to have work groups working on that and as we move forward with SIM. You may be aware that Henry Ford Legion's Health and the Henry Ford Health System, if you will, is a user of Epic. Epic is a new electronic medical record that will be coming to our community. And then our health department staff are actively engaged in being either super users or designated as people who have specific functions within the EMR, and I'm participating in that as well. We want to be part of this electronic medical record. There are lots of advantages to having that connection with our healthcare provider groups within the community. So we'll continue to work on that with the Epic Implementation Advisory Council. There is a press release included in your packet. We continue to work with the Rotary Club of Jackson in immunization outreach and advocacy efforts. There will be 4 billboards that'll be up in the community. They may already be up with the message, "We're protected, are you?" And the picture of 4 little children that are in that particular ad. And we're really excited to be able to continue that work with Rotary Club. We had a norovirus-like illness reported to us in April at a long-term care facility that has since been resolved. They happen every winter and spring, and this spring was no exception for that as well. Health education and health promotion, I'll drop down to that on page 4. Lots of updates and a lot of work continue to go on a really a weekly basis with both the abstinence program and the teen pregnancy prevention initiative. I'll be coming to you probably, I'm thinking next month, with an annual report for you, and we'll be highlighting the data that show the continued decrease in teen pregnancy and teen births, and as well as other things like infant mortality. So we are continuing to make progress. Under environmental health, lead poisoning prevention updates. We did participate in the lead expert panel forum on April 13th, which focused on lead paint in landlord-owned city property from the city's perspective, but we provide a lot of factual information concerning what the lead poisoning problem looks like here in Jackson County, particularly within the city, although there was some county data in there as well. We've had quite a few requests or inquiries concerning lead as well. I provided a presentation with the same content to the Jackson Area Association of Realtors on the 14th, and that was very well received. We've continued to help support the city's efforts for federal HUD Healthy Homes and Lead Hazard Control grant application. We provide a letter of support, and what the city intends to do with those resources is to use a lot of them to help provide resources for funding remediation and abatement and control activities and help fund that within the city proper.
Richard, I did attend your presentation there with the city council meeting, and you did represent the county well in your role. It was a challenging conversation when you looked at the dynamics within the room, and you and your panel did a nice job. One thing I just want to not only bring up to the commissioners, bring it to their attention, but then ask you a follow-up question. So it's my understanding that anytime a child goes to the Center for Family Health for medical services, part of the process that they have in place is to do that lead risk assessment. They evaluate the child's lead levels, or is that the way you appropriate
Pretty
lead
much,
levels?
yeah.
Okay, to see if they are elevated. So that is one component, but what about for all of the children that are not attending the Center for Family Health, are going to private physicians? Would you
Well-
address how that might be handled?
Yes, there are some pediatricians in the community, pediatric practices, as well as family medicine practices that are also screening. We screen up to about 1,000 children per year as well through the health department, through the WIC program. You may recall our conversation probably a month or so ago about the fact that the health department brought in 2 leased lead analyzer 2 units. We use the same unit that the Center for Family Health is using, and we really do our very best between the center and the health department and through the electronic medical record, which gives us access to previously test results of children that have already come through pediatric and practices, family medicine, and the Center for Family Health, to make sure that we're not duplicate testing children. We don't need to do that. That just increases healthcare costs across the board. So that's one of the things we identified through our lead screening team with the Jackson Health Network well over a year ago at this point in time, was we needed to get better about looking up children in the system to make sure if they haven't been tested that they get tested, but if they have been, that we follow up on any elevated lead results as well. So it's much more further along than it was 2 years ago in terms of the coordination of care and the follow-up. So, yes, you're right, that the center does do a lot of the screening as well. And we are also, back in 2007, the health department was a participant with the city in another lead poisoning prevention grant. The resources probably were provided up to about a 3-year time frame, but within that particular working relationship, we also had an MOU with the city on the specific activities the health department would be engaged in with that particular grant. And what we realized is when the grant went away, so did the kind of the sharing partnership relationship and communication about lead poisoning and lead issues within the city. So we're going to reconstitute an MOU with city that would allow us to share information with them and for them to share information back with us, so we can cross-match and cross-reference children who are identified as lead poisoning in the community with where their physical residential location is at. That'll help us connect up resources that the city has to help abate and remediate any home that a child is occupying. So that piece kind of got missed and lost when that MOU was terminated. So we're trying to reestablish that. It's a best practice. We had our Type 2 Water Supply Program annual evaluation for 2015. It was completed, and we have a really good program. We don't ever run into a situation where we haven't met the minimum program requirements, and a lot of that is due to Mary Farmer, who's one of our registered sanitarians who runs that program. So we had a very good evaluation for Jackson County. We do get reports of various types of environmental contamination from time to time that occur in the community. Don Hayduck and his staff usually get notified pretty expeditiously about those particular events, and on April 18th, there was an oil spill that was reported by the Summit Fire Department to the township, and we also learned about it through our routine contacts. It was relatively small, only 2 to 3 gallons of oil in a catch basin. Pads and booms were put in use, a vac truck responded, and there wasn't any impact from that particular event in the waterway. You're probably also aware, it's not in my report, but I'll just mention briefly that Don Hayduck has also been working very closely with East Jackson School District on their elementary school that they recently reopened. The school was closed for about 6 years, but it's been reopened now. And when water systems are allowed to kind of sit dormant for a while, there's a tendency for bacterial contamination to occur either because they have a closed loop, they have dead ends, they have some stagnant water in the system. So they've been working through this process for almost a couple months now to flush and rechlorinate the system to get rid of the bacteria. So just so you're aware, we work closely with them on that.
But obviously, they passed all the necessary requirements to open the school, and the water
did.
was fine at the time, and this is something that's just now developing.
Yeah, it developed, I think the first positive testing result was probably back in March. And so they've been working with us and the DEQ to get it resolved. So during some of this time frame, the school may actually have been on bottled water as far as drinking is concerned within the school building. But it's not related to anything other than that.
Commissioner Rice?
In regards to that, that water was tested and the water flowed through that school. Probably, even with all the renovations and everything they did, that water has probably been on at least 10 months. And yet, and there was no bottled water or containers of water like we have in the back of the room there available for several months. So I don't think it's necessarily accurate to think that they were using bottled water potentially, from my perspective anyway, from talking to the people through the school systems and everything else that I've been aware of this for a while. There is some concern about when this actually did start, as opposed to when they actually started getting good water. Just throwing that out there.
Okay, thank you. Some updates on the animal shelter. April 18th was the tax day sale. I didn't get in my report the actual results of that particular event, but I understand some adoptions did take place. There was a Friends of the Animals organized bowl for the animals Scotch doubles tournament on April 30th, and hopefully that information got out and people who could participate in that. And then we did have a grade reclassification for shelter attendance take place in April. And I think that's pretty much everything I have for you today. I'm happy to answer any questions.
Commissioners, what comments or questions might you have? Thank you for that information.
Thank you.
Next on the agenda, we have the claims from April. I believe they have made their way down. Seeing that we have a motion and support for the April claims, all in favor say aye. Opposed? Claims will be paid. Other meeting minutes, you will find we have the March DHS meeting minutes attached. We have a June reporting schedule. Department on Aging, Health Department, Lifeways, DHHS, Medical Care Facility, and Veterans Affairs. That leads us next to public comment. Is there anyone that would like to address the board? Seeing none, under committee member comments, I would like to start out. I would like to publicly recognize and thank Adam Brown. What many of the Human Services Committee members may not know is that as Human Services Committee Chair, I attend a variety of meetings, and Adam quite often is with me, attending especially DHHS and Medical Care Facility. And what Adam's presence offers at those meetings goes above and beyond. He is there and on site to get them answers to their questions, many times almost instantly. It keeps them from wondering what the answer might be and having to further investigate. His calendar has been very full, but yet he continues to make that a priority to those organizations, and I know it is very deeply appreciated by them, Adam, and also myself. So thank you for your service in that area, as well as many other areas, but that was one you just absolutely went above and beyond, and I'd like to thank you. Any other committee member comments? Seeing none, I'll adjourn to the call of the chair.